Hello, everybody. My name is Francesca Scalacci, and after I introduce the panelists, I will speak about what inspired me not only to create this webinar, but also co-found a nonprofit called Crutches. So with us today, we have John Johnson, Dr. Leighton Koo, and Dr. Brantley. And so John Johnson is a rising high school senior from Telluride, Colorado, who helped me start our nonprofit Crutches, which John will tell you more about in his PowerPoint. Dr. Koo, as a health policy researcher, a public policy analyst, and an advocate, Dr. Koo's career has been built around the effort to understand and improve access to affordable healthcare for vulnerable populations. Among his areas of expertise are national and state health reforms, Medicaid, the Children's Health Insurance Program, CHIP, immigrant health, prevention, and healthcare financing and budgets, with an emphasis on strengthening the healthcare safety net. As a member of the community, he has helped develop and guide the District of Columbia's Health Insurance Exchange since 2012 as a member of its executive board. Now we also have Dr. Brantley. Dr. Brantley is a senior research associate at the Center for Health Policy Research, Department of Health Policy and Management in the Milken Institute School of Public Health at GW. Her research interests focus on using rigorous quantitative and qualitative methods to improve healthcare and health policy. Dr. Brantley has examined issues including the healthcare safety net and the use of preventative services by low-income populations. And all right, so John will start with his presentation. And
before you do, can I just jump in?
Of course.
So I want to, first of all, welcome everybody to such an important topic. My name is Dr. Jiji Yumi, and I'm the founding director of the Rodham Institute, which is dedicated to improving health equity here in the District of Columbia. And the woman that you just heard speaking is Ms. Francesca, who is our Rodham Institute intern. She joined us from Colorado, from the Pinhead Institute, and we've been working with them for at least 7 years now, maybe now 8, going on 8. This is a program which encourages young women to go into STEM careers, and so we were just very lucky to have her work with us this past summer. And one of the areas of interest that she has had has really been around insurance and really being able to understand it, because it's super complicated to understand. And before I turn things over to you and have you introduce John, I just want to say thank you, because you've been amazing. You've worked very hard. She's a rising senior, and we're very in high school, going to college in another year. And she also has just been really so key to a lot of our initiatives and work at the Rodham Institute. And just to remind everybody, please stay tuned for updates about COVID vaccinations. We are now just getting word that all healthcare professionals, myself included, will need to get a booster. And we know that the Delta, although is not more deadly, it's much more infectious. So that means that unfortunately, absolute numbers of people getting infected, ending in the hospital, ending up in ICUs and dying is going to be much higher. And we know that vaccinations, although they don't necessarily prevent people from getting infected, certainly reduce substantially, if not eliminate, deaths from COVID. So please, please, please get vaccinated. And if you're not convinced or still have questions, please go to the Black Coalition Against COVID.org. That is one of the organizations that we're actually on the steering committee on, and I sure hope that questions will be answered. We've got a lot of town halls coming up. So with that, thank you to our panelists, and back to you, Ms. Francesca. And I'm going to sign off and just be a listener.
Thank you for the introduction. That was amazing. So John will start with his presentation, and I will share my screen as I have his presentation. So quick second. All righty. Alrighty, so this is Crutches. John and I started this nonprofit last year in the fall. So here's the story that inspired our nonprofit, and then John will take it away after that. So initially, I heard about this man in Teleguide who was making minimum wage, he was uninsured, and he was hospitalized due to COVID. And so now, unfortunately, he now faces a 125,000 medical bill. So it's a financial catastrophe, and it's not an uncommon story as well. So this amount of debt for a young adult who makes minimum wage is surely life-changing. This was, of course, of interest to me because I was personally uneducated about the healthcare system and was aware that many of my peers were as well. Given that my peers and I will soon be adults, John and I believe it is important for young adults to be educated about the healthcare system so that they can avoid life-changing debt like that of John Doe.
Hi, everyone. My name's John. And like Francesca said, after she heard this story that inspired her to start a nonprofit, she came to me and asked if I would be willing to help her. And I said yes. And so we decided to focus on why young adults are often uninsured. And so through our research, we discovered there are many barriers to young adults getting health insurance. And one of these barriers is a lack of awareness. And so why are people, especially young adults, uneducated about the healthcare system and insurance? So first of all, health insurance is generally not taught in high school, which is a big issue. And so young adults sort of expect someone to tell them to get insurance when they have to go out themselves and get it, but they don't know that. So, and then the people who do know that tend to feel more indestructible than older people. So for example, they think these diseases, pandemics, and injuries are less likely to really ruin their life with the cost of the medical bills. And so they just don't spend the time to do research and look into what health insurance they need. And that goes into the complexity of the healthcare insurance system, because even if young adults do know that they need to get health insurance, they can be confused by how it varies state by state, how there's public insurance, private insurance, and even subsidized private insurance. And the last barrier is high costs. So most young adults, after graduating high school, college, even graduate school, they have entry-level jobs that do not provide any health insurance. And so they have to use these entry-level incomes to try and afford health insurance. And health insurance can have varying individual costs and really high deductibles that make it super expensive. But one thing that can help young adults be prepared is that if you have parents that have an insurance plan, you can stay on your parents' plan until you're 26 years old. And so after researching this, we decided that our mission would be to teach high school seniors the fundamentals of healthcare insurance, so they will be prepared to navigate the complex web of the private and public health insurance system when they become young adults. Because young adults aged 19 to 34 are the largest uninsured demographic in the United States. And our short-term goal is to bring an educational program to Telluride High School and other schools in the region to educate them about this issue, starting this fall to fulfill our mission. And then our long-range vision is to bring this program to as many high school juniors and seniors as possible throughout the country. But we need help from organizations like the Rodham Institute to do this. So yeah, it's a little bit about crutches.
Alrighty, so Dr. Koo, you're welcome to take it away with your presentation.
Thanks. And it was really exciting to hear about crutches and the great work that Francesca, you, and John have been doing in starting an organization like that. That's so neat. And you're right. This is an important subject because young people really are one of the largest groups that have health insurance. So let me just start out with some basics about health insurance, and then I'll go into a little bit of the stuff that makes it complicated. So health insurance is super important, but expensive. And this leads to some of the challenges that John was talking about, where people think, oh, gee, it's going to be pretty expensive. And can I actually afford it when, I'm just starting out in my life or whatever? Even if you're older, you may still have, limited means to pay for health insurance. So it's worth understanding a little bit about some of the basics. And so one of the things I want to start off by saying is there's a tension between what people would like to have for health insurance. And so in principle, they'd like to have health insurance that will pay for all their health care. And the challenge is at the same time, people also want to have health insurance that's relatively inexpensive. And those two things work at odds with one another. And then there are certain components that are also problematic because of some of the strange history of health insurance and how it started. Health insurance started basically in the 1930s when hospitals said people are having a hard time paying for some of their hospital bills. So the original purpose of health insurance was basically to get together a lot of people who might have, no pressing medical needs, but everyone now and then might need to go to the doctor because whether you're having a baby, whether you fall down and break a leg, or you have cancer, periodically people do have these high bills. So that was the original purpose, was to have a way that you could bring a lot of people in and pay for those really high healthcare bills. Over time, this has evolved as people thought really the goal of health insurance is to basically help pay for health insurance in general, not just the high cost. I mean, originally health insurance was supposed to be sort of like home insurance. It's the kind of thing in case your house catches on fire or something horrible happens, that's what the home insurance is for. And that was the original purpose of health insurance. That has expanded over time. But because healthcare has become expensive, the original concept was that people would buy it on their own or they'd get it through their jobs. But it became so clear that it was too expensive for many people. So we have public insurance, things like Medicare, which is for senior citizens, Medicaid and CHIP, which are for low-income people and for children. And then most recently, the health insurance marketplaces that were created under Obamacare that are trying to help people afford health insurance. So that's how some of those things have evolved. One of the things that makes it tough for people who are new to the insurance market in general is that not only is it expensive, but it's really confusing. So part of what I want to do now is take, and I'm sorry to sound wacky, but I am a professor, so I am a wacky person by my nature, to sort of talk a little bit about sort of what are some of the main components. So I'm trying to share my screen. Hopefully you see this now. So the first thing is, what's the monthly cost of health insurance? How much does it cost? And we'll get to this in a moment. Actually, last year, just so you have a sense, the average cost of insurance for a single adult was around $7,500, and $1,300 of that was paid by the employee. This is not necessarily for young people. This is for single adults in general who therefore sort of average somewhat older. If you have a family coverage policy, that last year cost $21,000 in total. $5,500 is being paid by the employee, and the rest was being paid by the employer. So this gets at the issue, well, what are these components? So we start out by talking about a premium. And so a health insurance premium is the amount that gets paid to an insurance company for a policy. Usually it's paid on a monthly basis. So as I said, if it's $7,500 over the year for a single adult, what that means is that each month it's something on the order of $600 or $700 on average. This total premium is designed to cover the average cost of medical payments to health providers, and it's shared across all the people the insurance company is trying to cover. So it's not you individually, it's the entire group of people. And then there's an additional 10 to 15% in addition to what is paid to healthcare providers that goes for the administrative cost, reserves, and profits for the health insurance companies. So that's what that $7,500 in total is paid for. For job-based insurance, which is the major form of health insurance in the US, there are two parts. There's the employee share and the employer share. The employer share is what's deducted from your paycheck, and that's usually larger. And the employee share is the amount, the employee share is what's deducted from your paycheck, and the employer share is sort of there in the background. Essentially, it's being paid for instead of a salary. So the employee share is usually smaller. As I said, on average, for an employee, it was around $1,300 a year, so around $100 a month for the employee. For a single policy, if the policy is for a family, it's around $21,000 in total, around $5,500 by the employee, so almost $500 a month for the employee's share of the family policy. So that's so you have a sense of what the costs are and how they get there. The next question is, what do you actually get from your policy? And so this is, again, one of these things that becomes tricky and technical. One of the more important parts that you hear about health insurance is what's the deductible? And the deductible is the portion of the bill that the consumer, that the patient has to pay before the insurer pays anything at all. Up until then, that first part, the notion is that the patient will cover the initial cost. Some services, things like preventive care, so if you have screenings, if you have a COVID vaccination, for example, or care by certain providers, so maybe if you have under your health insurance policy, there are certain providers, they're covered without a deductible. So for example, I get my health care through George Washington University, my employer. If I see a doctor like Dr. Yumi at GW, then in that case, I don't pay for a deductible in order to see her. But the average deductible in 2020 was pretty big. So the average amount that a person was supposed to pay first dollar was around $1,600. After that, consumers sometimes have to pay co-payments and co-insurance. But let me sort of get to this whole square here. This is the total amount that people have to pay for healthcare in a given year. And this is what it's supposed to represent. So this blue portion, this is what the consumer pays. The next part the consumer pays are things that are called co-payments or co-insurance. And for co-payments, it means there's a set dollar amount. Like every time you see the doctor, it costs $35. Every time you get a simple prescription drug, it might cost $20 or $25. That's a co-payment. Co-insurance are for the bigger bills. That's typically a percentage saying that you, the consumer, have to pay 20%. The insurance company will pay the other 80%. So here, this orange part here is what the health insurance company is actually paying to the provider. So usually it's paid based on various contracts where the health insurance companies sets up contracts with some doctors, not all, with some hospitals, not all, to provide care. Usually the health insurance system is set up so that the actual payments that the health insurance company makes are heavily discounted from what the provider would call its charges or its list prices. So it's not uncommon that you might see something like the doctor would say, if you had to have knee surgery, my knee surgery bill would be $5,000. But the insurance company would say, no, based on our contract, we're only willing to pay you, the doctor, $1,000 or $1,500 for that knee surgery. So one of the things that health insurance is useful to have is to get those big discounts that insurance companies negotiate with providers. On average, this orange amount, the health insurance payments to the providers, that's what's really the main thing you're paying for the premiums for. The blue parts, the deductibles and the co-payments, are things that are covered services that you as the consumer have to pay something for. Finally, there are certain things that are excluded or out-of-network services. So sometimes health insurance does not cover certain policies. Fairly common things like if you have hearing aids, if you have dental coverage, if you need cosmetic surgery, that's not covered by your insurance policy. If you need out-of-pocket medications like you need basically Tylenol or aspirin, your health insurance is not going to pay for that. Then there are also exclusions that occur because of out-of-network services. So insurance companies sometimes say some providers are part of my insurance network, and some providers, doctors or hospitals or whatever, are not. So if you end up getting care from an out-of-network provider, then basically the insurance company is saying, this is not our responsibility. You have to pay for that. So if you get insurance, it's important to find out who their network of providers is, and to the extent possible, it's to your financial advantage to get care from some of the doctors, hospitals, pharmacies that are part of that network. That'll get you these discounted fees. If you see an out-of-network provider, it's going to end up being more expensive. So that, I'm sorry to say, is the sort of complicated thumbnail sketch of the way modern health insurance is set up. And at this point, I'll turn it over to my good friend, Dr. Aaron Brantley, and I will stop my slides.
Thank you, Dr. Kill.
I'll just say, Dr. Koo gave a great overview. One thing that came up, I was thinking of a young person like watching that. If you're out of college and looking for a job, considering the details of what's actually in the health insurance plan might be something that's relevant for you. We're in a situation where one thing that's happened because healthcare costs keep going up year after year and wages don't go up that much. Some of that is being shoved into premiums are going up and up. And a lot of it recently has been that pressure has gone into deductibles going up and up. So that's one place where people might have some influence is considering the options that are not just like what your salary is, like if you're looking at your first job out of college, but what are the actual details that are in there? Because you could be offered health insurance, but it could end up being pretty expensive. Unfortunately, even people that have employer-based health insurance can face pretty steep costs depending. And then other employers can be, still have plans that are relatively more generous. But thanks.
Perfect. Great presentation. And now we will jump into the questions. So this is a question for all panelists. How has COVID-19 impacted health insurance?
So COVID-19 had two sorts of effects on health insurance. Oddly enough, the first effect was it actually sort of reduced the cost. And that was because you may remember last spring, people were afraid to leave their homes. A lot of doctors' offices basically were closed. And in many cases, hospitals were only dealing with emergencies or sort of non-elective procedures. And so because of that, initially, healthcare utilization in the middle part of 2020 dropped off. So healthcare costs were not rising very much because basically speaking, people weren't getting much healthcare. Since then, it's increased the cost. And that's as things have become a little more normal. People are realize they actually do need to go to the doctor, whether through a telehealth visit or go in person. And doctors' offices and hospitals are open to a great extent now. Then they are bearing higher cost because there are additional costs for things like COVID tests, vaccinations, and for COVID treatments. The other thing that has been a little scary in the past year is that a number of people have held off on getting care for serious medical problems, things like cancer or heart disease. So actually, a lot of times people would normally have gone to the doctor to get sort of ongoing preventive and primary care. They've been stinting on that a little. So there's the need to sort of go back and realize people really should basically try to get some of that preventive and primary care.
That's great. Does anybody want to add on, or shall we move on to the next?
I would like to add on to that, in that the point that Dr. Koo just made is so important. As a result of just a delay because people were afraid of getting sick with COVID, there has actually been a drop in cancer diagnoses by 30%, which would seem to be a cost saving for the overall system. But a delay in getting diagnosed means that people will present at a much later stage of their illness, such as cancer, and will actually require more intense treatment. So let's think about this for a second. If a woman goes in for a mammogram and was found to have, a small abnormality, and it was cancer, it could be just removed, with a lumpectomy, if that's what she chose to do, or she could get radiation. However, if she has delayed her her screening until she finds a lump, or maybe the cancer sadly has spread, that's going to mean that it's going to be much, much more expensive. And sadly, the outcome won't be as good as if she got that screening in the beginning. And there are lots of reasons, of course, with COVID, why people were afraid to get screened, right? Or to even come in for testing because they didn't want to catch COVID. So COVID actually has had a negative effect on health conditions that are not even related to COVID, but just chronic health conditions. And of course, that's driving the cost up. So that's from a clinical standpoint. Obviously, I'm not an insurance expert, but that's my 2 cents.
That's a really good point. Yeah, I did not think about it in that way. So it's very interesting and sad as well. But
Right. So it's important. I mean, there are often regular checkups that people are supposed to have for care, or there's a certain how often women are supposed to have mammograms. But people need to get periodic checkups with their primary care doctor to see, do they have diabetes? Do they have heart problems? And in some cases, they can get some of their other issues dealt with. So it would be important to begin that people should feel a little more confident about going in to see the doctor again, and whether that's through telehealth or in-person visits, because otherwise they're going to lack some of those early services that can prevent much more serious problems.
definitely. So the next question is, how will young people, especially those who are long haulers, be impacted by their health insurance as a result of contracting COVID-19?
Aaron, you want to try that one?
Sure. Well, if people, for people that develop, who get COVID, I mean, the good news is that thanks to the Affordable Care Act, it won't have any impact on, what's under the pre-existing conditions protection, because we have these protections so that health insurance companies can't consider any of your current or past illnesses in their decisions about whether to cover you. So as long as those protections continue to exist, which looks like they will, there aren't impacts, and that's thanks to the ACA. On the other hand, you asked about like the long haulers. To the extent that people have these co-pays and deductibles, there's no like special rule about COVID being exempt from any of that. So to the extent that people need to be seeing the doctor, they will have just standard costs like they would for any condition that they were dealing with.
So if I could just add, because the long hauler syndrome, I don't think has gotten enough attention, but one of the aspects that it impacts is a person's ability to work. And if your insurance is linked to your work and you can't work anymore, that is something that's a consideration, right? So that could, but that's why the Affordable Care Act is helpful, so that even if you don't have work, you can still purchase insurance. But for people that have maybe been used to an employer picking up some of the cost of the insurance and not having that anymore, in so much as not being able to work because of feeling fatigued or unable to concentrate or having chest pain or shortness of breath, which are all symptoms of the long hauler syndrome, that can impact your ability to keep or have to change your insurance.
That's a good point.
And I'll just add, it's not just the financial cost. Obviously, the initial cost, or the real problem with COVID, is people get sick, and in some cases, their sickness is relatively mild. In a number of cases, it's quite severe, and so people end up on ventilators in hospitals. And those people who, even if they recover, may end up having the long haul. But that just reiterates why it's so important for people to get vaccinated soon to prevent this, why they continue to maintain good public health habits like wearing a mask, because we know that the Delta variant is just so much more infectious, just so that they avoid having these health problems as well as the healthcare cost.
Perfect. Yeah, no, I agree for sure. Get vaccinated if you can. Also, we have a question for you, Dr. Koo. What is a deductible and how does it work?
So the deductible, as I mentioned, is when you have a health insurance policy and this is for most private health insurance, there's typically deductible. So the deductible may be something like $1,000, $2,000. The average was around $1,600 last year. And what that means is, with certain services excluded, the first $1,000 or $2,000 that you incur in medical care costs, the insurance company will say, this is not my responsibility. This is the deductible range. That's what you have to pay. Once you've met that level, then we'll begin to pay something, and then we'll pick up care. The good part about this, well, the bad part is the deductibles are getting higher and higher all the time, as Aaron Brantley mentioned, which is, I mean, to me, $1,600 deductible is just amazing. And I've seen deductibles that are as high as $6,000. And you think, oh my God, that's barely any health insurance at all at that point. The good news is in many cases, policies say that certain things don't get counted against the deductible. So most preventive services, things like cancer screening, things like COVID vaccinations, COVID tests, they don't count against your deductible. They're always covered. In many cases, insurance policies will have certain other sorts of things that are excluded. So as I mentioned, because I'm on the GW health plan, if I wanted to see Dr. Yumi because she's part of our health plan and as a primary care provider, my deductible would not count against seeing her. So I would only have to pay whatever the copayment is to see Dr. Yumi, which I assume is something like $35 or $50, which is just a total steal because she's so great.
All right, John, I have a question for you.
That's pretty funny there. I'll pay you later for having said that.
All right, John, my question for you is, what should young people know about health insurance, and what advice would you give them?
Well, like I said earlier, healthcare insurance in the United States is insanely complicated. So my simple advice would be for young people to learn everything they can now about the health insurance system, so they don't fall through the cracks. And many people do end up falling through the cracks. And the proof is young adults are the largest uninsured demographic in the United States. So yeah, just learning as much as you can is the best thing you can do when you're young.
Perfect. And then I have a question for Dr. Brantley and Dr. Koo. What modifications can be made to the Patient Protection Affordable Care Act to protect young adults, in your opinions?
Dr. Brantley?
Yeah. Yeah, thanks. So I think we've missed what I just like, we haven't quite gone over. People under 65 generally get insurance from either employer sponsored insurance, like we've talked about, or through the marketplaces, or through Medicaid if they're low income. And so the Affordable Care Act had this expansion of Medicaid to cover many more people, still low income people, but many more low income people than it did previously. And then also the addition of the marketplaces for people that are largely self-employed or work for a small employer that doesn't offer health insurance. That's like basically how it that piece was to fill that gap because of the problems before for people lots of problems in what we call the individual marketplace for people who are getting insurance and it's not through an employer or through the government. So some of the there's holes that still remain. The main hole is for the low-income adults who are in states that haven't expanded Medicaid, who don't have options under the menu. There's no option for them. Basically, those are adults who are at 138% incomes that are 138% of the federal poverty line or less. The talk is—
Can I jump in for a moment to give an example to help make this a little clearer?
Yeah.
So for Medicaid, the income limit is, as in most states, about 38 states now, is around $30,000 for a family of three. So if you make less than that and you have a family of three, you're eligible for Medicaid health insurance coverage. In some states that have not expanded Medicaid, it's much lower. So my home state is Texas. I'm embarrassed to say that in Texas, if you are a mother and you're making $7,000 a year, you're too rich to be on Medicaid. And if you're a single woman or a single man, or even a married couple that doesn't have any children, it doesn't matter how poor you are not eligible for Medicaid. So that's why this health insurance expansion that Dr. Brantley was just mentioning is so important.
Yeah, thanks, Leighton. Yeah, so that's the main thing, and hopefully this will be addressed as one of many things that are potentially on the menu to be addressed in this major bill that Democrats are working on now. So options are being, or the other option is for the states, the remaining, those 12 states at any time can pick up the option to cover those people. Those particular 12 states just haven't yet. So that's the main thing. Another piece that happened was in earlier legislation that happened this year, some changes were made to the marketplace that just generally made it more affordable. So if you know people or you've checked the marketplace before and just of like a year ago and like, oh, this is just too expensive, just it was made more generous, but on a temporary basis. So the question, it would be helpful to people if those increases in generosity, like basically lower premiums, lower deductibles, could be made permanent. So that's another piece, because for certain, most like mainly middle income people, many people have reported that the marketplace options like looked too expensive to them and didn't seem worth it. So it'll be interesting to see how much this shift in generosity helps. But the reports are that millions of people have signed up for marketplace coverage since that change went through.
And with regard to rural and urban health, will that exacerbate health disparities, in your opinion?
People who live in rural areas have always had some problems getting access to healthcare in the same way that they have a little more of a challenge to get access to the groceries, to movies, whatever. It's just one of the challenges of living in a rural area. I don't necessarily think that the Affordable Care Act or some of the changes that have been discussed, such as Aaron is mentioning, have a direct effect on urban versus rural care. Now, what I'll mention is that a lot of the states that have not expanded Medicaid yet are more rural states. There are a lot of them are in the South, or there are places up in places like Wyoming or something like that, or I don't know Wyoming very well, but I think of it basically as there are a couple of cities and then a whole big rural area all through there. So the rural people get hurt by that. But there are so many ways in which we need to help strengthen the healthcare system for rural people. Actually, one of the things that's made a difference that's helpful is because people have been using telehealth so much more in just the past year or so. Telehealth is a big advantage for people who are living in rural areas. One of the major barriers was they couldn't see a doctor because in order to get to the doctor, they'd have to drive an hour or two. If now they can do this through an internet connection or medications just with a phone call, that makes at least some services much easier. Obviously, if you actually need to be examined by the doctor or to have a lab test or to have a procedure like some kind of surgery, you actually do need to be in person. But telehealth has definitely been a big advantage for people living in rural areas.
That's good to know for sure, especially since John and I do live in a rural area. But next question is, what should parents know about health insurance, especially when college students are starting school?
So, go ahead.
You go.
Okay. Especially if for college students, so they're the options that I laid out. There's a Medicaid marketplace and employer sponsored. The thing just to know about college students is if you're a dependent, a like for tax purposes, you're kind of tied to your parents' like tax information, your economic information. So to the extent that like the government is considering like what do you qualify for income wise, it would be based on not just your own information if you're not filing as a independent yet. So John already mentioned young people, if your parents happen to have insurance through their job, they can keep you on that health insurance up until you turn 26. So that many people have taken advantage of that. For low-income people, we've discussed Medicaid is available, particularly in states that have expanded, especially so for anyone that doesn't have children, that would be definitely, you would need to be in an expansion state. And if you do have children, you probably still need to be in an expansion state for the most part. And yeah, I don't know to the extent to which too many college students are using marketplace insurance. I don't know, Leighton, do you know? I don't know.
Well, the other thing that is available to many, but not necessarily all college students, is many colleges have a student health insurance plan that is relatively affordable. It's not quite as rich as what you might have in a regular medical care plan, but they're usually pretty affordable and will take care of the great majority of most routine healthcare costs needs that people have. In many cases, it might mean you have to go to a particular clinic that's associated with your school, but that's typically a good deal. The other thing that I think is worth noting, as both John and Aaron have mentioned, young adults under the age of 26 can be covered under their parents' policy. Where this sometimes runs into problems, if, for example, your parents' policy is set up so the network is designed to be really good in their local area, but where you've gone to college is someplace different than where your parents live. So, for example, let's say you are in Colorado, but you decide that you want to go to college in Washington State or to Washington, D.C., then in that case, your parents' policy might not necessarily be the best policy as it stands right now if all the doctors are primarily located in Colorado. So that's one thing where you need to think about the network. And in those cases, if you've gone to college out of state, lots of plans actually do include lots of out of state physicians and hospitals. But it's one of these things to check. Will you still be able to get care relatively easily where you've gone to college as opposed to where your parents live?
Alrighty.
That assumes that you're going to college, because not everybody is, right?
That's for sure. Yeah, so for those who aren't going to college, if they're young adults, again, they can still get covered under their parents' policy. But if not, they should look to whether it's Medicaid or their job or the health insurance marketplaces. The other thing I'll say that I think for a lot of people, this term that we're using, the health insurance marketplaces, is sort of still lots of people don't understand that they're the Obamacare plans. So, if you go to healthcare.gov to sign up for a plan, those are the Obamacare plans. Those are the marketplaces that we're talking about, that, as Dr. Brantley mentioned, we've made some efforts to sort of bring the cost down in terms of the premiums and the cost sharing elements for a lot of people. And really, we really do need to extend those policies in legislation soon.
So that kind of segues into our next question, which is, what services are available to individuals who are not insured? And for example, what if their children need immunizations?
I can answer this one. So Obamacare, like Dr. Koo said, is a public option for everyone to explore, but it differs state by state. Many states offer Medicaid to children whose families are living near or below the poverty line. And also in many communities, there are nonprofits that offer free immunizations for uninsured individuals and families. Like, for example, in Telluride, there's the Tri-County Health nonprofit who offers free medical services to the uninsured. So you can explore options like that.
For children, generally speaking, Medicaid and CHIP exist as public programs. And typically, and it depends somewhat on the state, but children are covered pretty broadly and pretty generously. So typically eligibility levels for Medicaid, where CHIP would stand for the Children's Health Insurance Program, go up to around 200 to 300% of poverty. So for a family of three, we're talking now somewhere in the range of $50,000 to $70,000. So you're getting distinctly into the middle class, where children would still be eligible for Medicaid or CHIP coverage. The other source where people can get care, in many cases, there are free or discounted healthcare services at places like community health centers, local health clinics. And so those are available all across the country that can provide sort of the outpatient care, the ambulatory care, your basic primary and preventive care. Where the problems end up a little more serious for uninsured children, just like for uninsured adults, is if they need specialty care, if they need care for cancer care or for diabetes. That's a little harder to find. But in many cases, you can get care through a safety net hospital, a local public hospital, or some other facility. But that's where there are some real problems. Fortunately, kids are mostly healthy.
If I can just add, because I think it's important that we also put this discussion in context. As a physician, and I think sometimes doctors, we overstate our own importance, at least in our minds. But the reality is that healthcare only accounts for about 20% of what contributes to how long a person lives for, right? So there are many pie charts that you can look up by Googling the structural and social determinants of health. Actually, 80% of what predicts how long a person is going to live have nothing to do with seeing a doctor, right? Because they're your education, the quality of the food that you eat, the economic health of your community, and of course, you want to have insurance, you want to have health systems that are there for, God forbid, those emergencies. But really, if we're going to make people healthier, we really should be investing in those things like food and making sure that children get fed, that there are great prenatal programs, that kids can graduate from high school. That has a very important impact. And if I could just say this, even though we spend the most money in the world, in the industrialized world, in terms of insurance, right, or healthcare costs rather, we have, I think we're number 37th in overall quality in terms of life expectancy and care for the money that we spend. So clearly insurance is a piece, and it's important that we know about it. But if we're going to advocate for really better health outcomes, and maybe, our esteemed panelists can speak about this, I think it becomes really important. I'd love to get the panelists' view on this.
Absolutely. Right now, you're seeing a slide from the Rodham Institute that's talking about some of the factors that affect your overall health. And so, as Dr. Yumi was saying, really only about 20% of your things like, how long you live and things like that are related to how much healthcare you get. But things like your health behaviors, do you smoke, do you exercise, do you eat well, your physical environment, how, is your building free of lead? And then things like socioeconomic factors like education, job status, and community safety also play a big role. So I think everyone's on board that we need to do more to sort of foster some of those things. I'll mention a little recognized change that the Biden administration just did. The Biden administration basically has just increased SNAP benefits. SNAP, that's what used to be called the food stamp program, by about 20%. They did this through an administrative change, but what that means is that more low-income people will be able to afford food through the SNAP program that'll last them the whole month. So that can also be important.
That's huge. I mean, that's really huge, because of all the social determinants of mental health, food is number one. So that's so important. And you're right, it's not getting a lot of recognition, but it's a very big deal, especially for those families that are impacted by it. So kudos to them.
And so I have a question kind of too, as we come close. Sorry, Brantley, Dr. Brantley, if you wanted to add on, you're more than welcome to.
Just really, really quickly, I agree with everything that was said. The one thing I think is also important to keep in mind is that health insurance is also financial protection. So other people have made this point. So not just sort of crediting health insurance with the health impact, which is maybe not so great, but also the financial impact, which Francesca, you started us off with. So protecting people from having a shift in their life trajectory to be something worse because they're faced with absolutely ominous, overwhelming medical bills.
Definitely. So as we wrap up the webinar, I have one last question for all of the panelists. Are there other countries that we can learn from regarding health insurance and care?
Yeah, I think New Zealand is a great country to learn from because their healthcare system is state sponsored and very good quality. It's funded through taxes. It provides free or subsidized medical treatment for residents. Yeah, New Zealand's a great one.
Actually, most developed countries do a better job than we have. So Canada does pretty well. Most European countries do pretty well. The sad thing is here in the US, we don't like hearing about other places. We think, gee, this is the United States. We must do things the best way. And it's not that way with how our healthcare system is set up, how our social benefits are set up. So we're slowly making some changes. So one of the changes, once again, that just occurred was a child tax credit increase. And that was really based on the experience of a number of European countries that really realized they can get some good social gains as well as health gains by basically helping families afford childcare. And I don't mean, going to sit in a childcare center. I mean, all the costs associated with children growing up, then, feeding them, educating them, etc. That's expensive for a family. So these child tax credits hopefully will pay off with better social gains. And we've seen that in other countries.
I just want to add, one thing that most countries, they tend to have systems that everybody, at least all citizens, have coverage. Other developed countries, all citizens have coverage. And there's lots of they take lots of different strategies to make that happen. So it's not just like what we have or whatever you want to call it. There's lots of different ways one can get to that outcome of everyone having coverage, and the government is involved to some extent, but private companies can also be involved. But they also they pay less for it. So that's another piece. And that is a piece that the Affordable Care Act, and that just largely we just as a society have not addressed. We haven't addressed the fact that every year a little bit more of the whole pie of what we have is going for healthcare, which is in part due to technology, and has also a lot to do with just how much political power different pieces of the healthcare industry has, and that trend has not shifted. So the question for me is always like, at what point will there be a breaking point when people are like, wait, too much of my earnings is going to healthcare? But there's going to have to be some other sort of political mobilization or some other something, I think, to actually get a handle on costs in this system.
Alrighty, well, as we wrap up the end, does anybody have any final thoughts? Alrighty, well, I would just like to thank every panelist for joining. And yeah, this was amazing. Well,
I have a final thought. I thought that, Francesca, you did a great job. This was
Thank
such
you.
an important topic, and we are so proud of you, our Rodham Institute intern. We also thank John for joining us today from Colorado, and of course, our esteemed panelists, Dr. Brantley and Dr. Koo. We learned a lot, and you know, I think that this is an area that we will continue to discuss for long periods of time in the future, because this impacts all of us. And it's kind of like insurance that tells you that you're grown up, that you have to think about health insurance. You know, it's like one of those markers that, uh-oh, I've become an adult now. I have to worry about these things. So thank you to everybody, but particularly you, Francesca, for choosing this topic and for bringing it to light and for convening such a wonderful panel. Thank you so much.
No, thank you for letting me do the webinar. It was amazing. And I would just like to advertise part 2 for next week with panelists Sarah Rosenbaum and Keith McCannon. So
great. And a special shout out to Ms. Ashanti Carter, who is the program manager and also helped and sort of behind the scenes in putting this together. So until next time, thank you, everybody. Be safe and try to convince as many people to get vaccinated. Take care. Bye-bye.
Thanks. Great being with you all.